Good morning, everyone, and thank you all for being here. I'm Lavelle Jones, AARP New Jersey State President and your moderator for this workshop. I want to thank the Black Issues Convention for this year's important conference and its ongoing work to enhance opportunities to exchange information among predominantly Black political, religious, social, business, veteran, student, labor, civil rights, academic, and professional organizations statewide. We're very proud to be here. Today, we'll be talking about a critical issue on so many people's minds, the high cost of prescription medicine. For millions in the United States, the cost of prescription drugs is an ever-growing barrier to proper disease treatment. This is most often the case for minority groups who've long experienced disproportionately adverse health access and outcomes. The National Academy for State Health Policy reported that low-income individuals and communities of color are besieged by poor access to healthcare, limited insurance coverage, and other health inequities that COVID-19 exposed. These communities also suffer another health disparity. They're among the hardest hit by continually rising prescription drug prices. People of all ages are skipping pills because they can't afford their medication. That's because Americans are paying 3 times what people in other countries pay for the same medicine. People are sick and tired of being price gouged for the treatment they need. So they and AARP are calling on the President and Congress to take action. We'll be discussing why we pay the highest cost in the world, the impact on real people's lives, and action in Congress happening right now to lower prescription drug cost. Earlier this year, AARP, on behalf of our 38 million members around the country, including 1.2 million members right here in New Jersey, endorsed H.R. 3, the Elijah E. Cummings Lower Drug Cost Now Act. The policies embraced by H.R. 3 are under debate now as part of the campaign to enact President Biden's Build Back Better infrastructure bill. We have a historical, generational opportunity to make real change that will improve the lives of millions, but it isn't happening without a fight. At AARP, we've tracked the prices of the most commonly used prescription drugs for well over a decade, and every year, the most commonly used prescription prices have risen faster, often much faster, than the prices of other goods and services. Our most recent RX Price Watch report, which looked at 260 widely used brand name medications, found that their prices rose more than twice as fast as general inflation in 2020. And that's in the middle of a global pandemic and a financial downturn. Prices are rising so fast that some New Jerseyans are forced to choose between the medications they need and other necessities like rent and groceries. With an average annual price tag of about $6,600 for just one brand name drug, that quickly adds up to more than the median annual income for people on Medicare. These price increases are unsustainable. So, what can the President and Congress do to bring down these outrageous price tags for prescription drugs? Well, you're going to hear all about that today from our terrific panelists. You'll also hear what you can do and how important it is for your voice to be heard. So now let me introduce you to our panelist, Danielle Combs. Danielle is a leader, activist, and servant. She serves in many capacities, including as the administrative director of the NAACP New Jersey State Conference. Danielle recently graduated with honors from Stockton University, obtaining her Bachelor of Arts degree in political science. Simply put, Danielle is a servant who enjoys serving others. As a woman of God, Danielle has served at Bethany Baptist Church in Lindenwold, New Jersey, as a proud member. Additionally, she's also a member of Alpha Kappa Alpha sorority. Danielle helped revitalize Stockton University's NAACP student chapter in the wake of a social unrest and she served as its president. She also organized the Juneteenth March for Justice on the Galloway campus in the summer of 2020, where over 400 participants were in attendance. Danielle commits much of her time to advocate for the rights of others and to hold legislators accountable. In her current role as administrative director, she continues to be the strong voice and representative for individuals who feel as though their voice doesn't have any power. Danielle aspires to go into law to protect vulnerable and underserved members of society in the near future. Ev Liebman. Ev is the Director of Advocacy for AARP New Jersey, developing and providing strategic leadership for AARP's advocacy efforts and campaigns at both the state and federal levels. Ev works with staff and volunteers to create positive social change and to deliver value to AARP New Jersey's 1.2 million members in the areas of health reform, retirement security, livable communities, affordable utility rates, and consumer and financial protections. Before joining AARP, Ev served as Director of Organizing and Advocacy for New Jersey Citizen Action, New Jersey's largest independent citizen watchdog coalition, representing over 60,000 family members and 100 affiliated community, labor, tenant, religious, housing, senior, and civic organizations. Ev worked in the labor movement for many years, organizing and mobilizing union members, negotiating public and private sector contracts, delivering and implementing member training programs, and focusing on numerous public policy sector issues affecting government services. Dr. Jibril Oyemi. Dr. Oyemi graduated summa cum laude from Lincoln University of Pennsylvania in 2005 with a biology and chemistry degree. He graduated from Penn State College of Medicine in 2009 and completed an internal medicine residency from Thomas Jefferson University Hospitals in 2012. He joined Virtua Medical Group as a hospitalist after training, at which point he moved permanently to New Jersey. He has since served as lead hospitalist and associate medical director of the Virtua Memorial, Voorhees, and Marlton campuses. He's also served on numerous committees, including the System-Wide Bioethics Committee, Physician Action Committee, Quality and Utilization Committee, and the Community Health Institute, which focuses on addressing health equity in South Jersey. He also created and managed a continuity of care program for hospitalized complex patients. After several hospital encounters with uninsured patients, in 2017, he founded the Cherry Hill Free Clinic, a clinic whose mission is to provide primary care to the uninsured at no cost to them. The clinic staff are a diverse team of passionate volunteers and hugely supported by local community organizations and health systems. By leveraging resources around, the clinic can provide quality care with access to lab, radiology, and specialists while completely removing the barrier of cost. Dr. Oyemi received the President and CEO Superstar Award, Dorothy Cox Fisher Community Service Award, and the Haj Musa Sabir Dedicated Service Award. He was named South Jersey Biz's Who's Who in Healthcare in 2019, New Jersey Biz Volunteer of the Year in 2020, and received the 2020 Congressional Martin Luther King Award for the work done at the Cherry Hill Free Clinic. He was appointed to join Governor Murphy's COVID Restart and Recovery Healthcare Advisory Council and the Governor's Task Force on Wealth and Equality in the state of New Jersey. In October 2019, Dr. Oyemi was appointed to serve as Medical Director of Virtua's Community Health Institute and the Medical Director of the Camden Coalition of Healthcare Providers. In this new role, he gets to work in the field of complex care. When not working, Dr. Oyemi enjoys time with his family, his wife of over 15 years, Naima, and his two daughters, Tasneem and Muna. What an illustrious panel. We are so fortunate to have all of you here today. Welcome. And so without further ado, let's get started. Danielle, do you have some opening remarks that you'd like to share with us?
Yes, I do. And thank you for that very beautiful introduction. To start, I want to thank you for allowing me the time to be here today, and I'm going to jump right into it. High prescription drug prices have had a severe impact on the African American community and are not just limited to new or specialized medications. African Americans suffer from chronic diseases at much higher rates than other groups and earn less money with which to pay for healthcare, including the cost of prescription drugs that they need to continue to skyrocket. African Americans are 40% more likely than Caucasians to have high blood pressure, and the rate of diagnosed diabetes is 77% higher in our communities. Patients of color are more likely than Caucasian patients to ration diabetes and hypertension medications due to costs. In fact, in 2014, African Americans were nearly 3 times more likely to die from asthma-related causes than Caucasians. African Americans are more likely to suffer from an expensive chronic disease and earn less money with which to pay for our health care, which is continuing to make this burden and continue to make this social gap expand within our communities. For example, a few statistics from 2013 to 2018, the average inhaler price rose by 35% from around $280 to more than $380. Similarly, a 1-month supply of insulin that cost $20 back in 1996 was $275 in 2019, which is a 1,200% increase. Across age and socioeconomic status, communities of color have had worsened health outcomes and less access to health services. Price gouging by pharmaceutical companies is one of the root causes of health inequities and is a preventable harm to communities of color. More than half, statistically speaking, 55% of uninsured Americans under the age of 65 are persons of color. For those with no insurance, paying retail prices for medications is often financially impossible. Furthermore, health insurance premiums are going up while at the same time, public health agencies are struggling to afford drugs and medications to cure these diseases that affect African Americans at disproportionate rates. Meanwhile, drug corporations spend billions more dollars on advertising than they do research, and $0 are spent on ethnic-specific research that includes communities of color specifically. Other developed nations pay much less for their prescription drugs than the United States because they negotiate with drug manufacturers. Also, most importantly, the public health agencies cannot afford enough important medications which save lives from opioid overdoses. We believe that no one should have to choose between covering the cost of the prescription drugs and buying groceries. We believe that these high-priced drugs are morally wrong, and a board is needed to protect vulnerable communities of color from the price gouging. Later on in our discussion, I look to expand on each of these opening remarks, but I will leave it there for now.
Thank you so much, Danielle. Appreciate those remarks. Ev, would you like to share some opening remarks with us?
Absolutely. Thank you so much, Lavelle. And thank you, Danielle and Dr. Oyeme. I'm humbled to be with such a wonderful panel this morning. So just bear with me a moment. I'm going to share my screen. Thank you. My name is Ev Liebman. I'm the Director of Advocacy for AARP New Jersey. And as you've heard, we New Jerseyans, Americans all across the country, are simply sick and tired of paying the highest drug prices in the world for their prescriptions. We just can't afford to pay more than 3 times what other people in other countries pay for the same medicine. As you've heard from Danielle, too many Garden State residents are forced to choose between filling their life-saving prescriptions and paying for rent, buying food, and meeting other critical needs. It's time for action at the state and federal level to lower prescription drug costs. And I want to thank everybody again for joining us to discuss the impact, of high drug prices on your wallet, your health, your families, and your communities. Now I just need to try and see. There we go. So let me just start by talking a little bit about some of the statistics that we've been tracking. As you heard from Lavelle, we've been tracking prescription drug prices for well over a decade, and know that on average, older Americans take 4.7 prescription drugs per month, typically on a chronic basis, which means that they're taking those 4.7 prescription drugs every month all the time. As you've heard, the average annual cost for one brand name drug is over $6,000 a year, and that was in 2019. And that was almost a little over $1,300 more even than 2015. And as you know, if you're taking 4 of those brand name drugs, it quickly adds up to the average Medicare income, which is only $26,000 a year. Danielle's already talked about how much pharma spends on advertising for its drugs. And from 2008 to 2018, pharma actually spent more on stock buybacks and dividends than on research and development. We also know, I just want to say, we've already talked about this, but not only is the cost of prescription drugs unsustainable, completely unaffordable for those trying to get by on the median income as a Medicare beneficiary, but most Medicare beneficiaries have less than $15,000 in savings. And so you can see just with that number alone, how quickly someone would find themselves in a position of simply not being able to afford the medicine that they need. So what are the impacts of these high drug prices here in New Jersey? And just to give you a snapshot of how many people we're talking about in New Jersey, more than 685,000 New Jersey residents have been diagnosed with cancer. These are the latest numbers that we have. Over 620,000 New Jersey residents have diabetes, and over 601,000 New Jersey residents have asthma. So you can see in these numbers just how many people are impacted by the high cost of prescription drugs. When we look at the prices to see what the increases have been for brand name drugs that are needed to treat these chronic conditions, we see just how much those prices have gone up. Here we see for Revlimid, a common form of cancer, the cost has gone up. And again, this is not necessarily what an individual may pay, but the cost that these pharmaceutical companies are charging. In just a year, Revlimid has gone up from $185,500 a year to $267,500 a year. Common drug that treats diabetes, Victoza, has increased from almost $8,000 a year to over $11,000 a year. And Spiriva that treats asthma has gone from $3,000 to over $5,000 a year. Certainly much more than a person's income has increased, particularly older residents who are on Social Security and are Medicare or Medicaid beneficiaries. So many people are wondering why prescription drugs cost so much, particularly why do they cost us 3 times more than any other country? The answer actually is simple, because there is simply nothing stopping drug manufacturers from charging high prices. Drug companies are making billions in profits off seniors and hardworking Americans. Other countries drive a much harder bargain with drug companies. But in the US, drug companies pretty much get to set their own prices. And as we all know, when demand is high for a product, companies often raise their prices. That's exactly the case for many of the prescription drugs that so many of us depend on. It's true, drug manufacturers have developed game-changing therapies for a host of serious illnesses, including multiple sclerosis, hepatitis C, and several cancers. But unless these medications are affordable, they are not accessible to those who need them. The drug companies entirely control the supply of a newer medicine because they hold the patent rights. This gives them a monopoly on the drug for the 20-year life of the patent. During that time, the drug company is able to raise the price as frequently and as much as the market will bear. Pharmaceutical companies have also become adept at using the patent system to extend their monopoly on a drug beyond the expiration of its original patent. For example, they can seek approval for a quote unquote new product that is a slight variation on the original. The longer that a drug company is able to maintain its monopoly, the longer it can continue to charge whatever it wants for its product. We also know, and you've heard this from Danielle, that drug companies spend a lot of money on advertising. $6 billion for advertising annually. Big Pharma justifies high drug prices, saying that it's necessary for research and development. But the truth is that all of today's new drugs have roots in government-funded research at the National Institutes of Health or leading academic centers across the country. Certainly that's true for our COVID vaccines as well. In addition, Medicare has no ability to put downward pressure on prescription drug prices. As one of the largest purchasers of prescription drugs, Medicare is blocked by law from negotiating prices. When Congress was debating the creation of Medicare Part D 13 years ago, actually a little longer than 13 years ago now, the drug industry lobbyists convinced legislators that giving Medicare negotiating power would amount to price control. But if you compare Medicare with the Veterans Health Administration, which is able to negotiate drug prices, the VA pays 80% less for brand name drugs than Medicare Part D pays. So in New Jersey, the average annual cost of prescription drug treatments increased 26.3% between 2015 and 2019, while the annual income increase for residents only increased by 21%. So here for the average New Jerseyan, we're already behind the 8 ball again. And for those who are living on low, moderate, and fixed incomes, they find themselves even further behind. I also just want to share with you some of the polling that AARP has done in all communities, including African-American voters age 50 plus, on their views of prescription drug costs. Similar to all Americans, 3/4 of African-American voters age 50 plus take at least one prescription medication, and 6 in 10 overall are at least somewhat concerned about their ability to afford prescription drugs. Nearly 2/3 of African-American voters age 50 plus believe that the prices of medication in the United States are higher than in other countries, so it's just something that we know in our communities. And African-American voters age 50 plus overwhelmingly agree that this year it's important for the president and Congress to agree to solutions to lower prescription drug prices. And finally, African-Americans 50 plus voters support various proposals to lower prescription drug prices. That support is very high. So what do we want? We want fair drug prices now. And we have launched a nationwide campaign along with many other partners and champions in Congress and here at the state level to lower prescription drug costs. We are advocating for passing legislation to allow the Medicare program to leverage its buying power as that large purchaser, the largest indeed, of prescription medications to negotiate for lower prescription drug prices. We want to improve access to lower cost generic drugs through competition. We have supported something called the CREATES Act, which is legislation that would ban drug companies from being able to pay a generic drug company to hold off bringing a generic drug to the market for a period of time. We want to limit out-of-pocket costs for Medicare enrollees so that they can afford their prescription drugs. And finally, we want to penalize drug companies who raise their prices above the rate of inflation in any given year. We believe that if Part D, that allowing Medicare to negotiate the price of prescription drugs will actually save beneficiaries $117 billion over 10 years simply from allowing Medicare to negotiate these prices. Inflation-based rebates are for widely used drugs will also save Medicare beneficiaries, but the entire healthcare system, significant dollars over immediately and then over time. And this really is necessary to combat the fact that in 2018, the brand name prescription drugs widely used by older Americans went up by more than twice the rate of inflation. And we continue to see that even after 2018. And as Lavelle said, even during a pandemic. We are seeking out-of-pocket caps to address the fact that 1.5 million non-low-income Part D enrollees entered into catastrophic coverage under their Part D plan in 2018. That Part D enrollees taking expensive drugs can face out-of-pocket costs that actually exceed $10,000 a year, almost half of the median annual income for a Medicare enrollee, and that drug companies themselves must be part of this solution in making meaningful contributions to access and affordability for the healthcare that everybody needs. Again, as I said, this is just a slide that breaks down support by African American voters, 50 plus. This survey was taken earlier this year, who have indicated extremely strong support for all 5 of these legislative proposals. Just want to also quickly mention that at the state level, AARP is also working to lower the cost of prescription drugs for New Jerseyans. We are working with legislative champions and community partners to establish something called the Prescription Drug Affordability Board in New Jersey. And what this is it would establish an independent body that would evaluate information about cost and pricing for commonly used drugs and establish an upper payment limit for what the state of New Jersey would pay for these medications. Again, an attempt to bring down some, to establish some competition and ensure that New Jerseyans don't continue to be price gouged by pharmaceutical companies. So finally, this workshop couldn't be more timely. Right now, Congress and the president are debating through the infrastructure bills that are before the House and Senate, how to lower prescription drug costs, including allowing Medicare to negotiate prices, establishing a cap on out-of-pocket costs for Medicare beneficiaries, and penalizing companies who raise their prices higher than the rate of inflation. We need to hear your voices, and we need you to take action. If you would like more information about how to take action and reach out to your congressional representatives and your state representatives, you can contact www.aarp.org/rx or www.aarp.org/New Jersey. I know we're going to get to questions and answers later in this morning's workshop, and looking forward to your questions. And just want to again say thanks for participating. And there's my email address if any of you would like any more information or have any questions. So Lavelle, I'm going to turn it back over to you.
That's terrific. And thank you so much, Ev, for that wealth of information. And I will say some startling statistics, and I'm sure we'll revisit during the Q&A. Now, I would like to turn to Dr. Oyemi, and welcome again. Would you like to share some opening remarks?
Yes, thank you so much, Lavelle. That was really a brilliant intro. Danielle, you hit on a lot of remarkable points, and Ev really just brought it home for us with all of that data. The point of view I'm going to share today is the viewpoint of a primary care doc who's in the office with a patient and going through the gymnastics of figuring out how to cover a necessary medication that we're going to find are not luxuries. So a good example is what Ev showed on her slide with Victoza. Victoza is a medication used to treat diabetes, and there's that category of medications. What you'll find is that these medicines, even though they are new, are medicines that have tremendous benefits in terms of cardiac protection, essentially meaning that your heart is you're gonna do better from a cardiac standpoint if you're on certain diabetic medications. So even though these medications are new, and some might argue that these patents that are held on to for a long time to sort of prevent these medications from becoming generic, even though they are new, these are medications that are necessary. These are medications that extend life. So there's a moral imperative here to really make sure that these are available to folks in the community, and just and these are not luxuries. And so a lot of chronic diseases, including blood pressure treatment, including I mentioned diabetes, but a lot of chronic diseases are things that happen to all of us over time. It's just the nature of the blessings of getting older. And so it becomes a shock, and it becomes very, very troubling to find out that the better medications to treat these chronic illnesses are not available, or that patients don't have access to them. And medications don't work if patients can't take them. I mean, that's just a fact. And so I'm really delighted and just happy with the fact that we're addressing these issues, and that we're talking about this to bring this to light. We can use all the help possible to help lower these costs and make these available to the community, because this is it's a public health crisis not to have these medications available to folks in the community. So I'm going to pause right there, and I know that there's we're going to come back to some questions and answers later on.
That's terrific. Thank you so much, Dr. Oyemi. And thanks to all three of you. You have already given us so much wonderful insight into this very complex issue. And so with that, I am going to lead us in to the next section, and that is our Q&A. We have a series of questions that we will ask each of you, and so looking forward to your expertise and comments. And please feel free for any question. You can always jump in and add your comments at any time. So with that, Danielle, I am going to come back to you, if I may, for the first question. And this is my question for you. Do you think that there is enough research being done on the impact of prescription prices on the Black and Brown communities?
Thank you for that question. I think that more research could be done. And for these reasons that I'm about to explain, we actually, the NAACP New Jersey State Conference supports the creation of a prescription drug affordability board that will have the authority to evaluate high cost drugs and set an upper payment limit that will help ensure the cost of drugs for New Jerseyans and communities of color are reasonable. So for that reason, I do think that more research could be done, more corporations and more money could be spent on researching and being specific to communities of color with a specific interest in communities of color. So that way they're not left out of the conversation, they're not forgotten, and they are included in as a priority and the reason why these prescription drug prices need to be more affordable for African American communities.
Terrific. Thank you so much, Danielle. And one comment on this question, it brings to mind another issue, and that is research in general on test subjects. For example, testing of vaccines or new medications. How many test subjects are actually members of minority communities? That's something that I think a lot of the scientific field are looking at now as well. We need to be included in the entire spectrum. So thank you, Danielle, for that. Dr. Oyemi, may I come to you for the next question? And this one, I'd like to get your input and your experience over the past year or so. Have you seen your patients have struggle with paying for their prescription drug cost?
That's a very, very good question. And the resounding answer to that is unfortunately, yes. And I mentioned earlier that the lens through which I go through, some of the providers go through, the office goes through, the gymnastics that has to happen with trying to figure out what medications are going to be available to treat a chronic illness like diabetes are just astounding. And it's to the point where we end up resorting to prescribing medications, older medications that we know are not quite as effective as the newer medications. This is, of course, after discussing with the patient that in a situation where they're unable to afford a particular newer medicine, rather than not do anything about it, would resort to prescribing the older medications, which often have worse side effects. And this is where it really becomes an issue. I'll give you an example. Things like an inhaler, right? Ev mentioned, she showed a slide of a particular inhaler that's used to treat asthma or COPD, which we know there are thousands of New Jerseyans who struggle with this illness. And inhalers for COPD or asthma are some of the most expensive medications out there. And it's hundreds of dollars, right? And these are inhalers that prevent, that have to do with quality of life, not needing to go to the emergency room as often if you're placed on these inhalers. And so it becomes deeply troubling to the point where in a place like the free clinic, which is one of my practices, we've actually just resorted to using donations to cover these costs for patients, because we don't want you to be, this is a necessary medication for your care. And so it's really quite troubling. And I'll just leave it at that.
Thank you very much, Doctor. It's important that we hear these stories from you and others who are dealing with these situations every day. Appreciate that. Ev, I'm going to come to you, and both you and Danielle mentioned the Prescription Drug Affordability Board. So I want to ask you if you could elaborate a little more and tell us more about what your hopes are for this board, or perhaps what they are specifically going to do.
Sure. Thanks, Lavelle. Well, as Danielle said, one of the important roles for the board is to do research and collect more data that's necessary to determine what a fair price for a prescription drug would be. And the board is really in response to that fact that we pay 3 times more than any other country for the medicine that we need. And what the board would bring together a group of independent experts who have knowledge in the field and who would evaluate the cost of manufacturing, the costs of research and development, compare prices that are being charged here to New Jersey, particularly through our large purchasers like our state health benefits plan and Medicaid, to determine based on all of that data what a fair price would be. And the board then would make recommendations to the legislature and ultimately establish an upper payment limit for what New Jersey would pay. It doesn't tell the pharmaceutical industry what to charge. It just says, this is what we will pay as the state of New Jersey. The board, a prescription drug affordability board has been enacted in the state of Maryland, and their board is beginning to develop its recommendations. Just a couple months ago, the state of Colorado enacted legislation to establish a prescription drug affordability board for that state. We've seen action in Maine and a number of other states to establish their own boards. And it really is in response to the high price of prescription drugs and recognizing that we have to rein in these high prices in order to protect our residents. Coming back to Dr. Oyeme's comment that drugs simply don't work if people can't afford them. And so the board is going to help ensure that everyone who needs a medication can afford it.
That's great. Thanks, Ev. And just a follow-up, is this affordability board already in place, or will it be in place in the future? Give us the status of that.
Sure. Well, legislation has been introduced in the New Jersey State Legislature. It has passed one committee in the Assembly. And right now the legislature is in recess, but hopefully they are coming back in November. And we will be working very hard to move this legislation through the rest of the legislative process and onto the governor's desk.
Terrific. Thank you very much, Ev. All right. Danielle, let me come to you, because I'm going to give you a wide open question, and please take your time on this one. Why is the NAACP in this fight to lower prescription drug costs? Take it away.
Yes, this is actually my favorite question. I'm so happy that you've asked. So simply put, the NAACP believes that healthcare is a civil right. And, everyone knows, for those who don't know, the NAACP is very adamant about fighting for the civil rights of others to be upheld. So we are involved in this fight to lower prescription drug prices because high prescription drug prices have a severe impact on the African-American community in particular. And it isn't just limited to new or specialized medications. African-Americans suffer from chronic diseases at higher rates. So we need someone to step in and fight for these high prescription drug prices to be lowered, because they're continuing to skyrocket and continuing to hinder and place a hindrance on the African American communities. As I said before, we believe that no one should have to choose between covering the cost of their prescription or paying groceries, or covering the cost of their prescription or paying bills. Such things like this for low income individuals, is a reality. So that's why the NAACP is involved in the fight to lower prescription drug prices, so that that can be one less thing that our communities of color has to worry about, their healthcare, which is a civil right and just needs to be upheld. Um, Everyone knows that prescription drugs don't work if people can't afford them. So if they continue to skyrocket, they're not working for the African American communities. We're not able to receive the same healthcare benefits, receive the same long-term benefits from prescription drugs if we're not able to afford them. So therefore, with all of that being said, we are involved in the fight to lower prescription drug prices, because we need to fight for much affordable prices in order to help eliminate the social barriers that are stacked against communities of color. And we know there are many social barriers stacked against the communities of color in particular. This is one of them that we are involved in the fight to eliminate.
Thank you so much, Danielle. I appreciate how well you articulated that. And I appreciate that you put it in the context of civil rights, because in so many issues that we're all working on, there is an intersection between social mission and social justice, and being able to influence in that space, I think, is really important. So thank you so much for that. Dr. Oyemi, let me come back to you if I could. Earlier in Ev's review, she mentioned how some of the excuses for rising prices are attached to the cost for research, development, et cetera. What is your take on the excuse that pharma needs to have high prices so that they can continue their research and development into new drugs?
That's a very good question, Lavelle, and that's one that's often cited in response to the high cost of new medications. The fact is, this has been looked into. There was a JAMA article, the Journal of American Medical Association, back in probably in the last 5 years. This article looked at data from 2005 or so, all the way up until 2016, and in all of that aggregate data, there was no evidence that the cost of research, R&D costs, really translated into an amount that explained the final cost that consumers have to shoulder. And this is, back to your point, Lavelle, and Danielle's very, very poignant point of how this ties into social justice, right? This is structural violence, because this is a clear example of how this particular issue ends up affecting certain communities more than others. And when you layer that on top of some of the historical happenings, right, and historical baggage from within the medical community, within the establishment, you start to see why this results in lack of trust, right? Because this is a clear case of profit over life, essentially. And so again, I'm just really glad we are talking about this and shedding light on this, because this is a public health crisis when you can't treat chronic diseases as well as we know we can in today's world.
Thank you very much, Doctor. Really, really important comments there. Ev, I am looping back to you. And we mentioned the Elijah Cummings Act. Can you give us some insight into what's the status of that act? What is involved in getting it passed? What's the process?
Happy to, and thanks for that question, Lavelle. So HR 3 which was sponsored by one of our very own members of Congress, Frank Pallone, and supported by many in our delegation, is now essentially being considered. The components of that legislation are being considered and debated within the infrastructure legislation that is being debated in Congress right now. Sometimes it's referred to as President Biden's Build Back Better infrastructure bill. And this is the legislation that focuses more on the social needs of our economy, whether it be healthcare, the need to provide supports for family caregivers, to expand Medicare. Sometimes we refer to it as our care economy. And so all of the components of HR 3, including allowing Medicare to negotiate prescription drug prices, capping out-of-pocket costs for Medicare beneficiaries, penalizing pharmaceutical companies for increasing prices beyond the rate of inflation, are part of that infrastructure bill. We actually are, as we record our workshop today, expect that there will be continued action on this legislation through the month of October, probably in the Senate at that point. And we continue to encourage our members of Congress, the president, to prioritize lowering the costs of prescription drugs and ensuring that they become part of this infrastructure bill.
Thank you, Ev, for that a review of what it's going to take for HR 3 to be passed. I appreciate that. We have about another 20 minutes or so left to our session. And this has been, such a great discussion that we also have received a series of questions from our virtual BIC audience. And I thought it would probably be a good idea if we could perhaps address some of those questions as well. And so first, I want to just let all three of you know this discussion so far has been even richer than I thought it would be. I have already learned a couple of things. So thank you so much. This is the kind of discussion that we in our respective positions need to continue to have as broadly as possible to get the word out. So wonderful comments and responses from all of you to all of the questions so far. So thank you so very much. With that, I am going to switch to some questions that we did get in, and let me throw this question out, and anyone can feel free to jump in. I think you'll all probably have some perspectives on these. So this is the first question. For people who aren't on the internet, how should New Jersey health programs communicate to people of color? How should these programs communicate to people of color about the things that are available to them, such as prescription savings programs or other support services? So anyone can go for this one. Ev, you have your hand raised. Terrific.
Yeah, that's a great question. And it's one that we have been really focused on in all of our work, but particularly during the pandemic, as we, by way of example, when the vaccines began to roll out and the only way to make an appointment was online, we found so many of our members and older New Jerseyans in general unable to navigate that system because one, it was either too complex, or two, they simply didn't have access to the internet. And we know that we continue to have a digital divide here in New Jersey, particularly among low income and older residents. In fact, the Pew Research Organization estimates that up to 30% of older New Jerseyans don't have access to the internet. So it's really important to educate folks not only about access to available programs to help them afford prescription drugs, but for other services as well. So we have focused a lot on direct mail, just sending information in the mail to folks, trying to get information out through public service television shows and radio broadcasts. Also by doing presentations with partners in the community, whether they be faith-based or in libraries or at schools and through other service organizations to try and to try and get the word out in ways that meet people where they are, is what I'm trying to say.
Terrific. Thank you, Ev. And Danielle or Dr. Oyemi, any comments on this issue of, reaching people where they are, particularly those who don't have internet access?
I'll jump in here. I actually echo everything that was already said. Partnering with organizations, for example, through the NAACP would be another good source to reach people where they are, it's particularly communities of color. Mailings, phone calls, other service organizations. I echo everything that was already said.
Thank you, Danielle. Okay, here's another question. Again, I will ask any of you to jump in on this one, and I'm not exactly sure. I'll read it to you. How's that?
Okay.
Why are Black population prescription drug prices highest for diabetes, hypertension, cardiovascular disease, and asthma? And again, this is a question from the audience. Doctor?
Yes, I'd be happy to take this one. So we know there's a racial disparity both in the incidence of certain chronic diseases, right, and the severity of them, right? And so what you find is within our community that what I'm seeing in the office is oftentimes, for example, high blood pressure, diabetes, it's gone unaddressed. It's gone unchecked for years, such that by the time, and it's gone unaddressed, this is key here, not because people don't care, but because in dealing with all the other structural issues that perhaps are beyond the scope of this conversation, but directly intertwined with what we're talking about. But when people have dealt with that, that struggle of everything else around them, right? It's no surprise that by the time they're seeing me, the blood pressure has gone unchecked and the 180 systolic, or their blood sugars have been in the 300s for years, such that by the time I'm seeing them, that's already affected so much damage that the medications that are now needed to manage those chronic diseases are more than what it would have been had we identified that much earlier on. But we know there's a racial disparity in that access to care. And again, that ties into why the medications needed later on when it's diagnosed, why those medications are much more, and also why there's now complications for which you need other newer medications that can help treat that condition. I hope that answers it.
It does. Thank you very much, Doctor. Really appreciate that. We have just a few minutes left to our session. It's amazing how time flies. And before we go to closing remarks, I have one more question, and this is just a general question again from the audience. What is the impact of COVID-19 on the cost of prescription drugs for people of color in New Jersey? And I think this is an open-ended question. I will make a comment just on my own observation and my own family and what I've seen in my experience. The whole COVID-19 experience, Doctor, to your point, so many layers that all of us have had to deal with. So I would say that the cost of prescription drugs during a pandemic has just heightened the level of anxiety in my sphere. So I will give that answer. Any other comments on the impact of COVID-19? No? Okay.
Well, I would just say, Lavelle, similar to your remarks, I mean, what COVID-19, has demonstrated on top of the devastating tragedy in terms of lives lost and serious illness, are the health disparities that impact our communities, particularly in African American communities who are disproportionately represented when it comes to many of the chronic conditions that we've already discussed this morning. But it also has lifted up the disparities in coverage, gaps in coverage, and including access to affordable prescription drugs. And so along with lowering the cost of prescription drugs, AARP continues to fight to improve access to coverage and insurance. Right now, for example, part of the infrastructure campaign that's going on right now would expand Medicare for the first time in many years by providing coverage for dental, vision, and hearing services. Very important to a person's overall health. And we know, for example, that African Americans have less access to dental coverage, to vision services, and to hearing coverage than to their white counterparts. And so expanding access through Medicare will help hopefully address and narrow some of those disparities that we've seen for too long in our communities.
Terrific. Thank you very much, Ev. Wonderful comments all. And I want to thank all of you. It really has been such a great discussion. I think you can tell I have so enjoyed it. It has been truly enlightening. And so as we bring this session to a close, I just want to extend many, many thanks to our terrific panelists. Once again, Danielle Combs, Ev Liebman, and Dr. Jabril Oyemi. And so with that, thank you all for joining us for this important conversation. And I do hope that all of you found it to be informative. I hope that you have learned some new things. And importantly, I hope that you are ready to take action. And here's what we mean. AARP's mission is to empower people to live the lives they choose as they age. We fight for and equip each individual to live their best life. And it's really all about real possibilities and ensuring that everyone has the health and financial security that they need. We believe it is just wrong that so many seniors have to choose between filling a prescription or buying groceries. And that's why we're fighting for legislation to lower prescription drug prices. The president and Congress agree that we need to lower drug prices. So now is the time for them to get it done. If you haven't already done so, please call your senator. The number is 800-891-7425 and tell him to lower drug prices now. Again, the number is 800-891-7425. With that, once again, thank all of you so much for joining us today, and thank you all for all you do every day.